everyone, and welcome to the CRC CARE Webinar series. My name is Prashant Srivastav, and I'm your host for today's webinar. As you're aware, the topic of today's webinar is impact of COVID-19 on the contaminated land sector. We are witnessing the biggest health crisis of our lifetime. We're all impacted by the coronavirus directly or indirectly. I'm sure you must be sick and tired of hearing the word COVID-19 or coronavirus by now. However, at the same time, you must also be keen to learn about its implications for the contaminated land industry. To discuss various aspects of COVID-19 and its impact on our industry, we have organized this virtual workshop inviting recognized experts from the health and contaminated land sector. Before we start the presentation, I would like to say a few things on the housekeeping. The duration of this virtual event is approximately 2 hours, and we encourage you to actively participate in this event by asking questions. The Q&A session is at the end. You will find a Q&A button at the bottom of the webinar panel. You can use the Q&A box to type your questions at any time. We will monitor the questions and our panelists will answer them towards the end of the event. You will also see a chat button at the bottom of the webinar panel. You can use it to make any comment that you may have about the webinar in general. For example, if you have any difficulty hearing us or viewing the slides or anything else, please let us know. For your audio, you have two options. You can use either your telephone or your computer speaker. If you have a poor internet connection, I recommend you use your phone for better audio quality. So please dial the phone number in your confirmation email and enter the meeting ID and password followed by the hash key. This webinar is being recorded and we will provide you a recording in the next few days. So without further ado, I would like to introduce the chair of this virtual workshop, Professor Ravi Naidu. He is the CEO and the Managing Director of CRC CARE and the Founder Director of Global Center for Environmental Remediation at the University of Newcastle. Ravi is known worldwide for his contributions to the contaminated land sector. Ravi, welcome.
Thank you very much, Prashant. To all those who are participating in this virtual workshop, welcome. I believe we have nearly 200 delegates participating today from more than a dozen countries. So to those of you who are from Australia, good afternoon to you. And those of you who are from other parts of the world, good morning and also good evening. I hope you can hear me really well. COVID-19 is something which we had never for once thought of. Going back 6 months in December, we never for once thought that our life would be disrupted the way it has been. But some people tell me that this is the greatest thing that has happened to them because their partner, particularly their partner who have been traveling a lot, they're now all staying home. It means a lot to them. And then there are some where the partners are staying home, it has led to considerable disruption, and also you might have read about breaking up of marriages as well. But going beyond households, there's been many job losses. From CRC CARE's perspective, we are all about working with the industry, in our case, environmental industry, providing support where we can, such that we can continue to provide guidance and support to the industry. And that's the reason why we are holding this workshop, a workshop that brings together medical professionals who know a lot about, in this case, infectious diseases, for us to let us know what it all means from infectious disease perspective. We have two medical professionals, one to tell us about the disease, the other who knows so much about contaminated land and who's worked with infectious diseases as well to tell us what it means working out in the field. But of course, we are fortunate that we have got practitioners who know all about contaminated site, assessment of contaminated site, remediation, and also in one case, basically a case study as well. So without ado, I would like to invite our first speaker in Dr. John Ferguson, who who is a microbiologist and infectious disease physician and conjoined associate professor with the University of Newcastle. Please join me in welcoming Dr. Associate Professor John Ferguson. Over to you, John.
Thank you, Professor Naidu. It's a pleasure to be here today, and I must say that I work in a hospital, in the hospital healthcare setting, so I perhaps don't appreciate all the challenges you face in your important work, and I certainly regard it as very important work, so I'm very pleased to help out today. I work up at the John Hunter Hospital. We've been caring for COVID patients both in intensive care and non-intensive care. Say thanks to our public health colleagues such as Craig Dalton and colleagues, we've been safeguarded from the terrible situation that Italy and, say, America has faced. I've just, in this title slide, I've unpacked for you COVID-19. We don't have COVID 1 to 18. COVID-19 is named by the year that it was discovered in China. So we've known about coronaviruses for some time. These 4 strains of coronavirus cause the common cold year in, year out. And there's an electron micrograph of the pretty virus with its crown-like appendages or spike proteins. We've got these nasty coronaviruses that have emerged since 2003, the first being SARS coronavirus that caused 8,000 cases, 700 deaths, and spread to 37 countries. That virus was quite different to this one and had differences that enabled it to be controlled. The MERS coronavirus from Saudi Arabia, 2,500 cases, 900 deaths or so, that is still present in the Middle East. And then of course this current virus, which in the space of 3 to 4 months has built up to 5 million documented cases, that being a fraction of the caseload in fact, because that just means 5 million tested cases and over 300,000 reported deaths. Again, a distinct underestimate of the true mortality. Now, our last pandemic was in 2011, not 19, with the H1N1 influenza pandemic, estimated 500,000 deaths with that, and a case fatality rate much lower than the current pandemic virus, case fatality rate under 0.1%, as opposed to around 1%, depending on which population you're talking about with the current coronavirus. So this virus differs somewhat from the previous SARS virus. This previous SARS virus, if you look at this viral shedding, here's the incubation period in the blue box, the symptomatic period, and the viral shedding really was maximal in towards the end of the first week of illness, and there wasn't really a measurable pre-symptomatic shedding of virus, which made it a much easier virus to contain because cases could be detected before they became infectious largely. Whereas with this virus, we had maximal transmission in the first 5 days of illness, very similar to influenza, and there's a pre-symptomatic period of infectiousness, possibly out to 48 hours prior to becoming symptomatic. There's a longer incubation period. How is it transmitted? So this is a very good report from China, a very large study of case reports from all provinces except the Hubei province, which was the main province involved, and 318 outbreaks were analysed, each with 3 or more cases, a total of 1,200 cases, and household transmission was responsible for 80% of those clusters. So usually within a household, it was 10 to 15% of household members that became infected. And the second most common instance of transfer was during transport, so closed environments like cars and taxis and public transportation. Only a single cluster reported from an outdoor situation. Here's a typical report from a restaurant, a large restaurant. The floor plan there gives you half of the floor, large restaurant, everybody out to lunch, and there's a pre-symptomatic index case A1 in yellow there who's excreting the virus, and over the space of some 2 hours under that air conditioner flying across the top, 9 secondary cases occurred. But interestingly, the other clients in this restaurant and the staff that were moving between the clients on tables A, B, and C did not become infected. So this is in accord with what we call large respiratory droplet spread, and not with what we call fine aerosol spread. So if, for instance, A1 had measles or pre-symptomatic measles, he would have largely spread to most of the floor of the restaurant via fine particle aerosols, and that didn't happen with coronavirus or COVID-19. So Twitter has become a very prominent part of the medical literature. There's a medical Twitter, if you like. This is a Scottish physician's report about 14 different studies, similar studies to the previous slide. And I just highlight a couple of things here about the enclosed environment transmission that's documented, that casual short interactions are not the main driver, and that children are not the main driver either. And most transmissions being caused by close contact with a symptomatic case in the first 5 days of symptoms, although a significant proportion occur pre-symptomatically. And so this physician, not unreasonably, is asking us to redesign our living and working spaces and rethink how to provide better ventilated living and working environments, and how we might avoid close sustained contact indoors in public transport and maintain personal hygiene. So this is part of the new normal, if you like, that we have to get used to. We're starting to get used to it. Now, how is COVID-19 diagnosed? It's diagnosed with direct PCR or polymerase chain reaction nucleic acid amplification test. There's no antibody test that's reliable. So that typically a nose and throat sample is taken. The laboratory extracts the RNA from the sample. The RNA is changed to DNA using a reverse transcriptase enzyme derived from a biological source. And then the PCR, the magical PCR process, amplifies up a defined conserved genetic sequence of the virus to quantifiable levels. And the production of that product from the PCR is detected by fluorescence within a tube. And you can measure the threshold cycle that sample has become positive. And that threshold cycle, the number of cycles to make it positive, gives you a measure of the prior quantity of template that was in the sample, the RNA template. So it's marvelous science discovered by an American who got the Nobel Prize for it, and this technology has underpinned all of modern molecular biology, including sequencing of viruses and bacteria in human genomes. In terms of clinical features of COVID-19 infection, it's largely a respiratory illness characterized by cough and fever, a dry cough, fever, and in a proportion dyspnea or shortness of breath. There are a range of other flu-like symptoms, and in some people they lose the taste of smell, or lose taste or the sense of smell, and that can be an isolated symptom. There are those that get infected and don't develop symptoms, and they tend to be children and young adults, but this has also occurred in people of any age. We can't really quantify what proportion of the population have asymptomatic infection. We are starting to see serological surveys of large populations indicating that quite a proportion of the population may be infected without a real signal if testing is not being done widely. So there's more to learn there. And here is the typical viral pneumonitis appearance in a severe case on the right on the chest X-ray. And these are CT scans of the chest showing what's called ground glass opacification. So these patients develop hypoxia, they can't breathe well enough, they require, a proportion require critical care or intensive care, and then ventilation. And those people that come to ventilation may have a mortality of 50 to 60%. It's a very complex illness to treat in intensive care. Just having a ventilator doesn't make the difference necessarily. Most patients on ventilation remain on ventilation for 3 weeks or so, which is highly challenging for the intensive care people to keep them safe from other complications of care. The mortality rate in red bars escalates by age. So here around 15% in the above 80-year-old age group. But if I showed you a plot for intensive care cases, the mortality is higher still. What about therapeutics? What have we got available to treat the virus directly? We don't really have anything of proven worth as yet. As I've mentioned, it's a highly complex disease with issues to do with thrombosis, so infarction of the lung, deep vein thrombosis. There's a whole immune response to the virus that occurs in the second week of illness in severe cases that damages organs and causes enormous oxidative stress within the body system, which damages tissues. So there's a lot more to learn about therapeutics, a lot of randomized trials at work, and it's stay tuned. Is there long-term immunity? It's too early to tell, but we think this may be the case in most people. The virus itself doesn't mutate nearly as quickly as the influenza virus, so influenza is known to escape immunity every year and we have to revaccinate. We are still hoping that this won't be the case with coronavirus. There's no creditable reports of second infections, and recovered patients may remain PCR positive with detectable virus, but we don't believe that they are infectious. Of course, there's many groups in the world developing vaccines. It's a tremendous effort out there, and some candidate vaccines have undergone animal trials already and are undergoing some initial human work. So I think we still won't see results, real results out of those trials for at least another 6 months. I'll just end with some approaches to infection prevention, and so I'm really coming from a healthcare perspective, but really the principles are the same wherever you're working. In healthcare, these are the 4 central principles: administrative measures around triage, early recognition and source control, standard precautions, transmission-based precautions, and environmental and engineering controls. And really, these are similar categories that you can take into account when you're thinking through infection prevention. So the first item, so in all our hospitals now, staff are subjected to screening on admission, on entry to the facility. That screening is mainly around asking them whether they have current symptoms of respiratory infection. Their temperatures are measured with non-contact thermometry. That's probably not the biggest thing. Questions and prompting hand hygiene at entry is an important aspect. And then of course we want to test symptomatic individuals so that we can put those aside and isolate them. We quarantine exposed cases and those who are awaiting a test result. So healthcare workers that develop symptoms get tested and have to stay off work awaiting that result and awaiting their recovery. A big problem throughout our societies is presenteeism, people who front up to work when they're unwell. And clearly that becomes an unacceptable standard to follow into the future, into the new normal. And so I think all our staff have to stay at home if they develop symptoms of respiratory tract infection or are unwell for other reasons. And I guess the capacity there is to work from home if one is uncertain as to whether they've got an infection or an allergy or something like that. So that's going to be a big change into the future. Next is standard precautions. So in healthcare, standard precautions are really what we want to be doing with every patient every time, because we don't know who is infected and who is not infected. So patients that come in may be asymptomatically carrying COVID-19 and represent an infectious risk. And so we have to have a system of measures that are unchanging across all patients. And those include hand hygiene, these items that are in the graphic there, I won't go through. Now, what are the non-healthcare setting equivalents? Hand hygiene, of course, work clothing hygiene. We can think about ways in which workers who might contaminate their clothing during the day, and I'm sure you're aware of all this as an issue, remove their clothing at the door when they arrive home and shower and change out of clothing. That's a good practice. physical distancing at work. So part of that might be involved more working from home so that the workplace is not crowded. And where we have to have a crowded indoor work situation where we can't observe physical distancing, then that is a situation similar to standard precautions where we would be recommending PPE use or personal protective equipment use. I'm going to mention Craig's paper later on. So here are here's the diagram about respiratory hygiene and etiquette. We'll be well aware of these measures. I think that's very much key to preventing influenza transmission and COVID-19, of course. In hospital, we are relying on droplet and contact precautions. These are additional transmission-based precautions. In large part, it's the surgical mask and eye protection that is providing the protection to the healthcare staff. Not all these funny things that you'll see on social media and on TV. The total body suits don't necessarily help. They're actually hard to get off without self-contaminating yourself if you've got a contaminated suit. So that's not for occasional comers. So I guess PPE in your setting would be more used for chemical contamination and avoidance of contamination from that point of view. It's a similar principle. Then lastly, environmental cleaning and engineering, which is relevant everywhere. I would say that cleaning is more important than disinfection. Disinfectants do not function well on dirty surfaces. That's the second key message there. But really looking at your environment to work out who cleans what, how is the cleaning done, and how you engineer your work environment to be safest from the point of view of respiratory viruses and other potential pathogens that might transfer in closed environments. So I won't labour the point about those. You'll receive these slides. Now, lastly, wanted to mention Dr. Dalton's paper recently published in the Medical Journal of Australia, which will circulate to you. And he has systematically thought through different environments that we live in and how the new normal might be brought in a low-cost manner such that we reduce the capacity for spread of respiratory infections such as COVID-19. And so I would commend this paper to you, the short paper. Here are some of his workplace low-cost hygiene and physical distancing interventions. So I'm sure Craig might talk about some of these. Some very good ideas there. These ideas were thought to have such merit that the White House, in fact, chose to highlight them in one of their briefings a few weeks ago. Craig's one of his moments of fame. And household-wise, these are some of Craig's listed measures to consider within your household itself. So I'll leave it there. Thanks very much for attending and listening, and I look forward to your questions.
Thank you very much, Dr. Ferguson. That was an absolutely super presentation, particularly you providing us an overview of the very different infectious diseases, number of people infected and deaths as well. I didn't realize that there are so many different ones, and that the death was so high in some cases as well. What we'll do is we'll hold back on questions right now, and we'll go to the presentation, and at the end of the all presentations, we will have discussion question time, and we'll bring the questions to all the speakers. So could you please join me in thanking Dr. Ferguson for an outstanding presentation. Thank you very much. Our next speaker is also someone who comes from medical profession in Associate Professor Craig Dalton, who is public health physician and conjoint associate professor with the University of Newcastle. Dr. Dalton, as I said earlier, he's a clinical epidemiologist, and he's very familiar with contaminated sites as well. Please join me in welcoming Dr. Craig Dalton. Thank you very much. And over to you, Craig.
I'm just going to whip through a few things, general principles, and then get down to workplaces at first. But basically, Sorry, it's not working so well. This is an attempt to describe what we were trying to do here in Australia and elsewhere in terms of flattening the curve. And you can see that this is what would have happened, and everyone was fearful. Obviously, we would have had a huge outbreak that really overwhelmed health service capacity, meaning that a lot of people didn't get the care they needed. And if they did get into hospitals, you know, they may have received substandard care because of services being overwhelmed. In Italy and in New York, you know, where the standard practice in ICU is to have one ICU nurse per patient, giving them full attention, that went down to one nurse covering up, you know, 4 and sometimes more cases on ventilators, which is just impossible and very dangerous. So the idea was it would keep the curve below healthcare capacity. And this is what we put in documents earlier, but actually we did better than this. We didn't even stress healthcare capacity so far in our first wave. You know, Australia's done so well. I'll come to some reasons for that. But I guess the reasons, well, we stopped the arrivals from China very early in February. We had a high level of PCR testing. That's the test that John talked about previously. So that meant we actually detected most of the cases and got them into isolation, including their contacts, so that if people fell ill, they weren't out in the community transmitting. Now, this high level of testing made Australia look worse than it was, leading to political action. A lot of epidemiologists were screaming and sleepless, and ID docs that, you know, there was inaction, we needed to do more. But what we didn't realise is that that actually things weren't as bad as they looked, because, you know, for another country with having 1,200, 1,500 cases, as we did in early March, without acting much, that would have been a disaster, because it would have meant there's probably another 5,000 cases out there that we didn't know about. As it was, there weren't that many cases we didn't know about. And it's kind of lucky because it scared the government into action and scared community too. So we had people yelling for lockdowns and closures, which was a good thing, I guess, because if you go in too early, then people want everything opened up too early. The other thing is the Ruby Princess scared the hell out of everyone. But fortunately, because they were well known, and they were mostly told to go into isolation when they left, and it was on the media, we had very little secondary transmission. So we had a massive increase in cases, you know, coming in, but we didn't get the secondary transmission we could have. If that had been an underground rave in the middle of a forest and, you know, 1,000 people had been to it and then all left dispersed and not known about, it would have been a disaster. And then we had the social distancing kick in from the 23rd of March. So all this helped us a lot, but probably the arrivals, stopping arrivals and closing our borders had the biggest impact. We were lucky there. So February 1 when the travellers from China were stopped, and then all the overseas arrivals going to isolation here are important. You can see by the time a lot of the other controls, such as putting people, return travellers in hotel quarantine, we're well on the decline here. This is the travel ban on foreign nationals entering Australia here, and some of the physical distancing in public venues. And then it was around the 23rd of March that we started I think the pubs and clubs were shut. So we'd already hit the peak by then, and that just helped things decline faster. So going to, you know, what is useful for in the workplace, John's mentioned the article, and it was funny, and I think Paul Nathaniel's circulated a link to the preprint, but John was mentioning the final paper. So I go for the final paper, which is in the MJA. But, you know, it got a lot of reaction, the preprint, and then the final article in the MJA, like 5 weeks later, got no attention at all because everybody knows about physical distancing now. So it's not such a big deal. I think one of the things in that paper is it does push this idea that we want low level, if we're going to have transmission, and we will, let's make it as low level as possible and as low dose as possible, because there's a theory that the smaller the dose we get, the smaller the health effect. And all of you in risk assessment know this well. So we actually think it probably does apply. It's not as clearly applicable in infectious disease. In fact, some people believe there might be like a non-threshold effect. For some viruses, you either get it or you don't, but the animal experiments certainly suggest that the bigger dose you get, the more severe illness you get, and potentially the more infection you spread because you're emitting higher doses when you're really sick of the bug. So any little barrier that we can put in place to decrease transmission will be important. And so I recommend all the recommendations you'll find on the Safe Work website. I'm just featuring it here. You can find Safe Work Australia. And I particularly like to point to, this is the one that I think can be, where is it? Okay. It's not there, but I can't enlarge it. But if you look at this one here, physical distancing checklist, recommend that one to you, because a lot of the questions we get, what do we do if we can't physical distance? What do we do if we've got to have two people work on something and get really close together? And I think that is the place to look, that checklist. And it talks about things like, well, if you have to have two people working together on something, just have them do it for the very minimum amount of time. And if they have to do it, don't have them facing each other. And then it goes on further down through the checklist and even gives advice on using personal protective equipment to perform functions that might have people face to face. So I'd recommend that. Just going. So what does the future hold? Well, basically, even though it's not that clearly articulated, we're probably not going the New Zealand elimination route. We try and remove it completely from the island, and maybe New Zealand aren't either. Definitely haven't gone the Sweden controlled transmission with a lot of deaths associated with that, hoping that herd immunity kicks in. They've also suffered significant economic impact, so they haven't actually escaped economic impact by letting the virus transmit more freely. And they just didn't shut down their shops and restaurants and pubs and things, but they did do social distancing. We're probably more likely going to follow the South Korea suppression and release model. And what that means for us is that for quite a while, we're probably going to have this kind of on again, off again thing where we've had our first first little wave. It's hard to call it a wave, it was a tiny little wave really compared to what we could have had. And the subsequent waves may well be bigger, so not like this graph. If we're lucky, it'll be like this one, and that all the subsequent waves will be lower and lower level suppression. That's very unlikely, but it's something that we can try for. And basically we'll have, are likely to have more recurrences like this. And the blue section here is where we've realized that the cases are coming up. We're getting a risk of overwhelming our health facilities. So the blue section is putting suppression orders in. So that might be decreasing the size of gatherings, closing down some high-risk venues. And that's probably what we're in for over the next little while. The probability of a vaccine in the next year or two is low. If they get it, it probably won't get to us first. When it does get to us, it'll probably be given to essential workers first. So we probably have to plan for the earliest vaccines, being made early next year and getting to us much later. And I might just stop there. I just have to, sorry, Ravi, I thought we were taking questions as we went. I have to go to another COVID-related meeting. So I could either take a few questions now or someone could text me to come back at the end. I'll leave it up to you.
Great, thank you very much for your outstanding presentation. Ladies and gentlemen, we had two outstanding presentations, and given that Dr. Dalton will be leaving us shortly, I would be happy to take questions for Dr. Dalton now. So let's devote next 5 minutes to questions and answers. Any questions for Dr. Dalton?
Okay, well, I'm sure John can handle any of the questions that I could have taken anyway. So I'll say thank you for inviting me, and good luck with the few months. Yeah.
There is one question for you, Dr. Dalton. This is from Keith Osborne, and the question is: are the mutations sufficiently diverse that there are regional strain level variations? Variations?
Yeah, so certainly there's been some overseas sequencing, fingerprinting that has shown variations and allowed people to identify some routes of transmission between countries. So far, local sequencing has not suggested a lot of difference between different clusters that have occurred here, and so it's not going to be as fine a fingerprinting as some sequencing, but there is regional variation at a global level. John, do you have anything else to say on that?
No, not really.
No. Okay.
The question that I have, Dr. Dalton, Taiwan, for example, people are talking about Taiwan, how well they have managed this. What difference do you see between Taiwan, the way they have managed, for example, between that and Singapore, another small country, and then coming to Australia? It's a large country that we have, but the density that we have, population density, is not the same as what you would see in Singapore, for example.
Yeah, look, I did a comparison to the centre of Sydney with overall Singapore, and it wasn't that much less. That was kind of interesting if you take the centre of Sydney where there have been cases, but perhaps the level of mixing in public transport is not the same. But let's just say Taiwan, of course, is the standout, and I think the thing that stands out for all countries that have done well, if you take Australia, Taiwan, New Zealand, Singapore did do very well, except for when it got in the migrant workers in those great big condominiums. So that was their problem, but they did do very well. So they're all islands, which is one thing. The other thing is they all did a lot of testing and they weren't surprised. The places that have done very poorly were surprised. So it could take 4 or 5 weeks to declare itself, going through 6 chains of transmission. Most people having a mild disease, not getting sick. And if you're in a country where you only start recognizing you've got an outbreak when there's 5 or 6 people dying, it means you've got hundreds, thousands of people out there with the illness and it's been transmitting for weeks. So that was the big difference. Now, of course, Taiwan also has their mobility levels across society went down months before ours did. So the whole society, because of where they are, the experience with SARS, expected this and they reacted to it. The whole country did, well before we did. And so they weren't surprised at all. They were prepared. A lot of people wore masks, which probably does protect and prevent community transmission, notwithstanding some of the downsides. But I think all of that added up to put Taiwan and in a very good place.
So here's another question for you, Doc, from Dr. Ilya Rosami, is a scientist. Which one is worse, COVID or the fear of COVID?
Look, there's a lot of people are saying the response is overblown and, they compare it to flu. Now, as John mentioned, sure, the initial estimates of case fatality rate were high, but they probably were high in hospitals that were overwhelmed. They could be 4 times higher, 5 times higher in hospital that's overwhelmed. If it just sits under, say it's 0.7%, just under 1%, well, that you could say that's 7 times worse, say, than a bad flu year, or 4 times worse than a bad flu year, depending how you count them. In terms of case fatality, but then if you multiply that by the fact that only 10 to 15% of people get flu in a flu season, where if 50% of the community got this, you're multiplying by 5 again. And so it's not just how fatal it is for one person, it's how many more people will have a fatal outcome in the community because there's so many people infected. You just have to realize that you just have to see bodies being stored on ice rinks in Spain to say, well, is that the kind of way we want to live? Do we want to have a whole cohort of young doctors and nurses, or even old doctors and nurses, basically, destroyed psychologically by this horrible onslaught if it was left uncontrolled, and the way people would die in isolation, in hospitals? It's just not and nursing homes just being closed down with dead bodies being taken every day. That doesn't look like flu. That's not what our flu seasons look like, and I don't think we want that outcome.
And a final question, Doc, a couple of questions. One is from Dr. Sagar Gawande. Thank you for nice explanation. Question is, how and why this COVID lives in varied temperatures Is it programmed?
Well, a quick comment on the temperature. I'm not sure if I'll answer the question, but you know, typically when a pandemic virus emerges, it can emerge any time of the year. Usually, like coronavirus, influenza virus, prefer winter when it's cold and dry. But during the pandemic strains, you know, the 1918, the 2009 pandemic, they are quite happy to emerge in, you know, fall, in spring, and spread during summer. It's usually the subsequent years when there's more immunity, then they tend not to be able to spread so much during summer.
And the final questions, anonymous attendee, is washing hand with soap for 21 seconds enough to keep virus away? How reliable it is?
Look, it's again talking about, you know, a dose effect. That's 20 seconds of soap and water is an amazing reduction in the amount of virus that would be on a hand. So that's a really good thing to do. And if everyone did that, that would certainly wipe out that hand-based transmission of the virus. It wouldn't be a concern. So that's a really good thing to do and very effective.
I would say that so the virus is disrupted by the detergent of the soap, for sure. But an essential part of hand washing is the drying step as well. So you like to use towels, you know, paper towels for drying, because you can recontaminate your hands after the drying step. The drying step actually removes 10 to 100, you know, 1 to 2 log of bug from the skin, as well as, you know, hand washing and drying go together.
Thanks so much, John. Thank you very much, Dr. Dalton. Ladies and gentlemen, can you please join me in thanking Dr. Dalton for his outstanding presentation.
Thank you all very much, and good luck over the next year in contaminated land and uncontaminated hands, I hope. Yeah, take care.
Thank you. Ladies and gentlemen, we'll move forward now with our next presentation. That's Dr. Peter Nederbaum, principal from GHD. Peter has been working as a contaminant specialist for many years, and I always say that what I've learned about contaminant site assessment to a very large extent from two senior consultants, Peter being one and the other being Ross McFarland, who is going to speak as well. So could you please join me in welcoming Dr. Peter Nederbaum. He's going to speak about COVID-19 contaminated site work. Over to you, Peter.
Thanks, Ravi. Yeah, look, I'm very pleased to share what, in fact, my knowledge is obviously a lot less than Craig's and John's knowledge related to the medicine, the medical perspectives. What I'm doing is going to share with you, from the practical side of things, from the the practice of consulting, and what we're seeing. It's a personal view. Look, it doesn't represent a formal company view or an industry view. So it's just my observations and what I've been seeing. Yeah, from our company's point of view, which is interesting. Yeah, and I think we're probably typical of consulting companies. Obviously health and safety is paramount. It must not be compromised. And we've got a very high ethic in that regard. The mission is to protect our staff, our colleagues, families, the Australian population. We must comply with governmental advice. And what the company did when the COVID-19 came about, it prepared a management guide, which was quite very informative, quite comprehensive, and it listed all the relevant government advice, Australian as well as key overseas advice, and it provided guidance on how we should, as a company, be addressing the issue. And so that was a pretty good initiative right at the start. I've been very impressed, actually, that we made the transition to adapt and respond to the virus very quickly. and I was surprised how quick it was. And what I found out was that the company had been doing scenario planning, over the last year or two beforehand, looking at these sorts of things. And so we came in to the issue really not having to just start from scratch, but having had planned responses to scenarios of this type. And that, I think, was pretty important in allowing adaptation in days rather than weeks or months. And we have things like a wellness program, the focus on safety, and so we have a broader remit within the company to address these things, to address the issues that arise, not only just straight safety, but also the broader staff wellness. The other thing I was very impressed with is that there was an immediate gathering the senior staff together, and to decide that if there needed to be support in any way, then the senior staff would provide that support to the business. And things like taking leave if necessary, and so on, to maintain the business, maintain our employees, to not lose key people in the process if that was becoming an issue. I don't think it's become a particular issue, but the response was there, and I've seen it in our companies prior to that in previous years. I've been around a long time, and 10, 20, 30 years ago with significant downturns, and the company senior staff being ready to step into the breach is an important thing. Our IT group enabled working from home within a few days across the entire business, which was, I think, an amazing thing. They had been working towards it, but I think the transition was going to take about 6 months. And so when the virus came up and the need to work from home almost immediately, then they deployed Microsoft Teams and Zoom across the business, enable these platforms to be taken up on everybody's computers remotely, and so on. And so that to me was an impressive thing. And so what we see there, as a consulting business, the business is going on, and I'll bring you to this too, but in fact, maybe even with higher levels of efficiency. In terms of the office, our office, the morale is good. Continued without a pause, but everybody's working now from home, so dramatic change. Very few visit the office. There's only a few people who might go into the office who need the technology, the printers, large printers, large screens, and so on. So it's very few, and they would only visit the office on approval. There's also what's interesting, I think, things like virtual group activities have cropped up, immediately sprung into place. Our weekly group meetings have always taken place in the office, but they're now virtual group meetings. Friday night drinks at the pub is now carried out on a virtual basis. There's lunchtime quizzes and so on. So that all the group activities, that key issue of trying to keep people together as a group and linked is going on. And also, so these are general observations. I'm getting to the site details, but things like webinars. You'll have all seen this. I think that there's a large number of webinars now taking place, sharing knowledge, local and international. There's almost too much sharing of knowledge at the present time. You don't have time to participate in all these things, but it's interesting. What you do see is that these web sharing platforms aren't perfect. There's often, intermittency in them. Sometimes you need to work around trying to get onto them, especially if you're going to be a participant. That can be a level of, an order of magnitude higher difficulty than just simply listening. And we've found a bit of mixed success with some platforms. We have, and I think other companies will have the same sort of thing where we have security concerns about some platforms. The company won't support them because of security concerns, and so they become less able to be used as readily. Looking at our clients, the companies that we work with, generally we're seeing that there's still a requirement for compliance. This is environmental compliance, regulatory compliance, and so if there wasn't that, then a lot of this work might tail off very quickly. But our clients see that need for compliance continues. In some cases, it's practical response to delays caused by the virus and the complications that engenders, so that we do see some delays. But the way I see these displays are that they're largely second order and relatively minor, and the intent there is to maintain a general level of regulatory compliance. The government projects are largely continuing. So the large infrastructure projects are all continuing. A few non-government clients have been hit very badly, and they've just put projects on hold where it's been discretionary, where they've been able to do that. And so we see that, but overall, most of the projects are going on. And social distancing, our clients take that on board. They impose requirements, and so that impinges on us. We can't necessarily have as many staff on site. We don't want to, they will limit face-to-face meetings. Their key issue is to avoid coronavirus coming on board into their operation, and that which could cause a major upset to their operation. And so they've got their business particularly to think about, and that imposes then risks on, poses constraints on our business. And in the contaminated site field work, as I said, it's continuing on with overall with only relatively minor change. The job safety environmental analysis that we carry out routinely for all projects or field work, it's been expanded to include the coronavirus. We have practical limits on travel, where only essential approved travel can be undertaken. In some states that would be only within states. Certainly a great restriction on any international travel, or that probably just does not occur at the present time. Comply with state requirements, because there is variation in state requirements, state to state. We have travel management plans, hygiene management, accommodation, when there's travel and the accommodation that's required, the sanitary provisions and so on. So we have guidance around these things and the constraints that apply. The issue of social distancing is a key one, and that probably has perhaps a significant impact, where we practical impact. We minimise face-to-face meetings of project teams. They're online meetings or only one-on-one with social distancing. So the normal project team meetings that you might have are very much changed. They still take place, but they're changed. Field work continuing with social distancing on site. Our staff now must go in separate cars. Contact with the client staff is limited, because the client doesn't want people coming on site unless it's absolutely essential, and to minimise that. Interstate support to field work is stopped. So normally we would move people around from state to state as needed, and so we're now tending to work within states more. The drillers in the laboratories are still providing services. As far as we can see, the supply chains are still working. So we're getting all the support work there is still carrying on. What we do find, on-site work where we have subcontractors, drillers and things like that, we need to review their arrangements, make sure that they're doing everything they need to do to maintain social distancing, hygiene, personal protective equipment and so on, make sure all of that is appropriate. This can take considerable additional time, and so we've got to allow in our programs for that review and for that to be complied with. Where we as a company have control of the site, then we will develop a site-specific COVID-19 management plan. And this includes all the details of travel to site, site access, site amenities. You can see these listing here, avoiding close working and cleaning and control and review of contractors. So all the sorts of things that you would think, but they're carried out on a systematic basis. In terms of once we've carried out the site work and then coming back and reporting, there's really little change to our existing procedures. A lot of that is desk work, which can be carried out from home. We've got, as I think all consultants will have, an efficient shared report preparation. We can have a number of people working on the same report at the same time. Our IT systems are good, and I think that's broadly across the industry. Virtual meetings and workshops occurring where things need to be discussed. So it's generally carrying on as per usual, but probably more from home and more with virtual meetings rather than face-to-face meetings in the office. And so auditing work is really a subset or another part of our site assessment work, and it's quite related, and it's much the same where the work is going on. So overall, we have adapted as a company, and I think the industry has adapted. Life and work's going on wonderfully, that no one that I'm aware of is sick. Some field work is simpler. It can be carried out more easily because we've got less traffic on the roads. If you're sampling an airport, it's a pretty good place to be sampling an airport. Drilling and things like that at the moment, much easier than it would have been previously. And less costly. Some things become slower and more costly, with client delays and distancing. But overall, as I see it, life is going on, and we have adapted. So, Ravi, that's my quick summation of what I see from the practitioner's point of view.
Thanks very much, Peter. It's another excellent presentation. The way GHD has managed COVID-19, both within the confines of our building and also interacting to sites and sampling, and also shows that to some extent there's cost implications as well. So, ladies and gentlemen, could you please join me in thanking Dr. Peter Niederbaum, and we will have question time after all the presentations. I also see that we have Dr. Paul Nathaniel who is joining us, who has joined us. So Paul, get ready. We might ask you to say a few words at the end of the presentation. Our next speaker is Mr. Ross McFarlane, who is the Chief Environmental Scientist with AECOM, Australia and New Zealand. And I would like to invite Ross McFarlane to take us through his presentation, with the focus being the impact of COVID-19 on remediation. Could you please join me in welcoming Ross McFarlane? Over to you, Ross.
So here's my presentation. I wanted to cover some background to start off with about how I gathered the information together, and then provide an overview of the contractor's approach to deal with this. I've been able to do a little bit of analysis of this work, and I found that the information divides into two types of. I'd like to go a little bit more about that consideration a little while, and I'll bring you off to some colleagues to have a look at beforehand, and they said it's thick with text and I really need to put some pictures in. So here's the picture, and this is from the web, and it talks about COVID being something with an intermission sort of issue rather than a long-term kind of one. So with that in mind, I went to the contractors and asked them what they thought of the situation. Now, ACOM is not a contractor, but we are a good listener, and we're a good group gathering information together. The consultant's view, and so I wasn't going to cover that. And I think we consultants, as a rule, have done pretty much along the lines of what Peter was talking about in the methods and responses. And interestingly, James's presentation from the owner of contaminated sites perspective, you'll see a lot of comparisons there as well about what the owners of sites have been doing too. So I haven't gone into the detail of those kinds of things, but I have provided some specific observations. And how did I do that? Well, I interviewed some of the Australian remediation contractors. I interviewed brownfield site specialists, including Paul, who's online, and he had a look through this presentation at midnight or so last night and is up at 5 o'clock in the morning or something like that to listen to it. So I really appreciate Paul being there. I also spoke with some colleagues in the Superfund program in the US, specifically in Region 8, and I interviewed a colleague, just one from Environment Quebec, to get his views on things. And then I also attended 3 brownfield COVID impact webinars along the lines of what Peter Naderbaum was saying, and that there's lots and lots and lots of information out there. These ones were good. They were about an hour each or an hour and a half each, and they were specifically in relation to the impact of COVID on brownfield sites, and some of them related to planning, others related to how consultants dealt with it, and others, really usefully, talked about contractor impacts. So I gathered that information too. That includes in Australia, in New South Wales, UK Constructors Leadership Council, which Paul might just think about. He was part of the team that put that information together, and it was released yesterday, the 19th, or maybe today, the 20th of May. I also picked up the US EPA protocols that have the information from Environment Canada. So I gathered the information from all of those different components. And by far, the interviews with the Australian remediation contractors. So this is the information that I found. This is an overview of. First, contractors around the world have been impacted this coronavirus, and so they've had to deal with the same kinds of constrictions and constraints as we had, restrictions and constraints. Things continue to move very quickly, so keeping up with all of this is absolutely essential. Next, remediation contractors have not been impacted as much as the wider construction community. I hope you can still hear me. Okay. Peter Naderbaum, can you wave your hands if I'm coming through okay?
We
Thank
can
you very much.
Yeah,
so remediation contractors have not been as impacted as the wider community. Sorry, one thing I have noticed is if somebody rings you and you're using your phone as the wireless connection, it tends to cause all kinds of problems. So my apologies for that. I don't know how to turn it off. So anyway, remediation contractors have been quite innovative in responding and changing to these things. In fact, they've been using local workforces to reduce the travel and border restrictions. They've amended work practices such as where house site amenities are being used. Their sign-in, sign-out procedures have been less face-to-face. Inductions have been more remote. The toolbox meetings have been more remotely associated, and auditing of performance, compliance auditing, health and safety auditing, and those kinds of things have often been done remotely with others involved on the ground, sending back information remotely to the audit teams. That's compliance auditing kind of work, I mean. Some UK remediation contractors have developed an interesting site accommodation facility which, and perhaps Paul Nathaniel will could speak more about that. That was where people would stay on site rather than leave the site. And there was a bit of debate about whether or not that was a riskier proposition, and would it fulfill all of the government restrictions, space, social distancing and the like. But obviously it does. They made much larger areas, so it's not sort of bunk accommodation. It's much more like small apartments that have been put onto the site. One other thing from an overview perspective is some equipment has been problematic to deal with, especially specialist equipment that is usually brought in from interstate or from other countries. These border constraints have made that problematic. One of the big points that I think I've got from the discussions is that the work has been very much siloed, and I'll try to explain what I mean by that. So I've used a mindset or a paradigm which is consideration of white-collar workers and blue-collar workers. So for white-collar workers in the remediation industry, there hasn't been a significant impact on productivity. In fact, as Peter Naderbaum said, in some cases we've seen an increase. People in the white-collar side have been able to work around the restrictions, not meaning avoiding them, but being able to work more effectively without being constrained by those restrictions. There's been some work postponed in that white-collar area, especially for private sector work, but usually that's not cancelled unless it's directly associated with sales type issues. And I'll talk a bit more about that in a second. There's been obviously some upsides for white-collar workers in being forced to learn how to use these digital communication systems and the associated online productivity and digital collaboration tools, which have been working both formally and informally, as Peter Naderbaum was saying. And another upside is enforced personal hygiene with, as Craig Dalton was saying, there is a likely beneficial outcome in that the normal flu transmissions are likely to be reduced as a consequence of the personal hygiene and reduced commuting and reduced use of public transport. But from a white-collar remediation perspective, that's been not a very big impact, but it has been an upside. And there's been an overall increase in the knowledge and awareness of the company's operations due to increased communications and training. It's along the lines of what Peter was saying earlier, again, for all companies, in that they're talking more and communicating more and getting the message right across, and there's a lot more training going on than there ever used to be. So there's some of the very positive things from a white-collar perspective. From a blue-collar perspective, not quite as good. Some impacts, especially for working for people involved in one-on-one contact, where they can't use digital tools. That's been a problem, not so much in our industry because of the way that we work and the PPE and social distancing that we all have anyway. There's been some difficulties in being able to get to work around the restrictions, but it still is possible. So that's the crossing borders to get to and from work and on-site social distancing. There certainly has been a greater amount of blue-collar work being postponed, especially for the private sector. And there's been some work cancelled for field works due to a domino effect where land development has been postponed, and there's a concern that there might be too much of a market delay to recover from that effect. So that work has been actually cancelled rather than postponed. The same communications upsides occur for blue-collar workers as white-collar workers, although they might not be as easily able to take up some of the digital links that are available from a personal hygiene perspective. Same upside in terms of communicating the company's operations, but again, dependent upon those blue-collar workers being able to plug in. From a broader perspective, Peter, you can still hear me and it's all going well still? Yeah, good, thank you. So many remedial projects are being postponed or delayed, but few have been cancelled. My colleagues in the remediation industry have said that there's a softening in the pipeline, especially for the oil and gas sector. And as I mentioned earlier, there are some projects directly linked with housing developments that have been cancelled as the sales for those housing developments have slumped, and there's an expectation that their recovery from that slump won't occur quick enough for those remediation projects to be viable. That's only for projects that haven't actually commenced, by the way, I think, but maybe Paul Nathaniel might speak more about that. And in the UK, Paul provided me this last night, some previous government-based brownfield support is now being redirected towards greenfield sites on the basis that they're generally considered to be faster delivery mechanisms. So the UK government has got a real urgency for housing, and the government planners are now thinking that maybe they should direct some of their energies into greenfields, which are easier to turn on than brownfields. And there's also this discussion about that I think Dr. Douglas mentioned, which is about changing the design of the way we live to redesign the scale of spaces that we work in and those sorts of things. Maybe we could talk about that in the Q&A session. Just a few other considerations. Some contractors and also consultants have been redirected, or they've been furloughed, as the UK people will call it, or they've had reduced hours to protect jobs in the long term. And sadly, this, in some cases, has led to redundancies as a result of modified business plans. And that's especially true where there's a significant work program that's being developed by the contractor for, say, the oil and gas industry. And with the slowing down of that gas industry work, underground storage tank removals and associated works, infrastructure development works that relate to the type of remediation that we do, those jobs have become much harder to keep busy, and so there's been a modification in the business plan, and that's led to some redundancies, sadly. On the upside, though, the contract negotiations with clients for delayed delivery of projects to take up this period has been very collaborative and very positive. And many clients, I've been told, have been very supportive about changes to the contracts to agree with later delivery, and also, very nicely, shorter payment terms, like so that when the restart begins, there's not a 40 or 60 day turnaround for invoicing. So that's a very positive outcome. So in conclusion, 6 quick points about conclusions. There have been challenges in remedial contracting, but not to the same extent as the general construction industry. And that's because of the way our remediation industry operates in the main. Remedial contractors have been quite nimble and innovative in their response. Clients have been supportive. There's been a lot of cooperation and communication, so that's really been a key. Peter, you can still hear me? Yep.
Yes, we can.
Thanks. There's been an impact on the pipeline, especially in relation to the oil and gas industry. Expectations are quite positive, especially for government and private sector work, which is good. There's been many benefits to the remediation industry, including improved work communications, enhanced training, and there's a significant knowledge, and all of the remediation contractors that I've spoken to are very sensitive to this issue. Some especially have been saying that they really appreciate the efforts that blue-collar workers go to. The biggest risk for a white-collar worker is going to Woolies to buy food in the evenings. The biggest risk to blue-collar workers is being out with the people commuting to and from workplaces. So a much higher risk they bring back to their family. I'd like to, in closing, acknowledge the contractors that have provided information to me, Ventia Ford Civil EPS, the international contacts that gave up their time over the last few days, and especially Paul Nathaniel, who's online, who reviewed this draft and provided suggestions. And Ravi, I'll hand back to you now.
Thank you very much, Ross. Ladies and gentlemen, another excellent presentation. In this case, implications to remediation industry, and it's good to see Ross, you being able to get information from both contractors and remediators, and indeed from Paul as well. What's is going on in UK. It's quite sad to see that COVID-19 has led to redundancies as well, which of course is a major concern to so many of people. So ladies and gentlemen, I would like us to move forward with our last presentation, and I would like to invite James Stanning. James Stanning is Senior Environmental Technologist with Orica. And James will take us through Orica, what they have put in place, including some case examples. Please join me in welcoming James.
Ravi, for the opportunity to participate in this. I think that some of my thunder has been stolen by the previous speakers. They've done an excellent job, but I'll try to do my best not to duplicate things. And this, unlike Ross's presentation, I haven't done nearly as much research as he has, and this is much more related to our experiences here at Orica. So what I thought I'd first of all do for some of the people who are listening in, they may not be aware of who Orica is, so I thought I'd just talk quickly about that. Then I'd talk a little bit about the impact of COVID-19 on our workers, the work that we do, but also people doing the work as well. And then also what sort of measures we're taking to overcome some of those impacts, not just for our people, but also for our operations and our projects that are happening in different parts of the world. So Orica is, these days, it's purely a mining services company. We are the world's largest manufacturer of commercial explosives and blasting systems that get used in the mining and quarrying and oil and gas industries, and also in some construction work as well. We also manufacture sodium cyanide for gold extraction. And coupled with that, we provide some ground support services, which are rock bolts and resins for rock bolts and the like, for mining and tunnelling. We've got about 11,500 employees operating around the world and working in about, well, more than 100 countries around the world. We've probably got operations in more than 60 countries as it is. Historically, though, we used to be known as ICI Australia, and as part of ICI, which was a big British company that manufactured all range of different chemicals. Here in Australia, we had a wide range of manufacturing beyond just the explosives and blasting systems that we have now. There were chloralkali products, so that's things like chlorine and caustic soda and hydrogen and a whole lot of derivative products from there. Chlorinated solvents and paints, pesticides, a whole range of different explosives to what we manufacture these days, including dynamite, small armaments and munitions and so on. It's a rich history there that goes back a couple of 100 years in some instances. And pigments, fertilizers, surfactants, and a whole lot more. And the reason I say that is because we have a whole range of different legacy issues, not just here in Australia, but also in countries abroad. And that's both from our historical operations, but also the companies that we've bought over the years. And I just thought I'd use a few of those as examples for today's presentation too. Most particularly from the Botany Groundwater Cleanup Project, which some of you might be familiar with in Sydney. There's also, I'll touch on a remediation project we have down in Melbourne in the suburb of Yarraville. and also talk briefly about the impact on a site characterisation work we're trying to do in a site in Chile. So what's the impact of COVID-19 been on our work? Well, obviously we're having to deal with illness and self-isolating, and that illness might not actually be COVID-19, but how we actually respond to people who may or may not be symptomatic, and who may or may not be Orica employees as well. And obviously that has impacts on, we've had to change our workplaces to accommodate the physical distancing, and make many adaptations around personal hygiene and the like. And I won't elaborate those because I think they've all been talked about enough today. And then there's the great phenomenon of working from home. And Ross said that, you know, that's happening to a lot of white collar workers. Well, indeed, Orica is no exception to that. I suppose in some respects, Orica is a little bit lucky insofar as we have a lot of experience with remote workers and so on. So the company has always been quite well geared for that and for remote working. And of course, all of that comes with its pluses and minuses. Obviously, there's the challenges of home versus work. We're all told we have more available time for both of them, but I'm not sure that that's necessarily the case. I think it just continues to be a balancing act between the two, and balancing the expectations versus the reality as well. And of course, also there's the challenges that I think both Ross and Peter alluded to with issues of connectivity and the facilities that people have in their individual homes, such as printers and wide screens and so on. Then there's the whole issue with supply chains. And obviously for a manufacturing company, that's a big issue for us, but it also affects our remediation works as well. So it covers both goods and services, and I'll talk a little bit about some of those impacts as well on some of our specific projects. And then, of course, there's the whole issue around cybersecurity. There's obviously a lot of people with malicious intent out there, and this just this pandemic creates new opportunities for them to exploit. And so there's measures that need to be put in place to overcome some of those challenges as well. The whole impact on people, of course, is a real mixed bag, and I quite like this diagram when somebody sent it to me. I think it demonstrates many of the pluses and minuses of the impact of COVID-19, but there's so many more issues related to it as well. I'm sure that each of you could probably think of a dozen more things that you could add to that mind map about the pros and cons. So what sort of management measures have we been putting in here at Orica? Firstly, for our people, from a safety, health and environment point of view, our safety, health, environment, security section has been doing an inordinate amount of work. In fact, very early on, the company activated its crisis management team and put in place many of the well-established processes to manage such a scenario. Obviously, this scenario, the pandemic, is quite different to one that we've confronted before, but it's a well-drilled management team that is experienced with, was well-trained in dealing with different company-wide issues. In terms of the CHES support, that's come mainly via SharePoint information that's been shared company-wide. And that covers all sorts of information, including monitoring information about COVID-19 and expert advice on that. And in particular also, I think, providing advice on what is good and what is not so good information. There's a lot of misinformation out there there's a lot of information being provided by people who really don't know much about what they're talking about. And so I think that it's been very helpful to have our own internal professionals vetting that information and providing a filtered resource to us. There's been a lot of advice around actions to take, whether they're short-term, longer-term actions that need to be put in place, and the sort of protocols that need to be enacted. And there's many FAQs and the like as well. And of course, there's been advice about travel restrictions. And as Ross, I think, said, most people aren't travelling now, but there's still one or two that still have. Conversely, though, we also have people who are more or less stranded in overseas locations, either voluntarily or involuntarily. In fact, we've even had instances of where expats have chosen to stay in their locations to help out the local manufacturing site, and more particularly the local customers as well. So these are examples of some of the protocols that we've been developing in-house, and they cover all sorts of different aspects. And just as an example, the one for cleaning and decontamination, it's just a simple 2-page document that provides all key information that people can quickly look up and go through and work out, do their gap analysis and work out what else needs to be put in place. There's also a lot of other documents that have been provided in terms of guidance documents and further information and frequently asked questions, various tips and so on, covering all sorts of different aspects to ensure that, to the extent possible, that work continues on as best it can. Our human resources team has also been heavily involved in making sure that people are coping with the changed circumstances, and they've been particularly using Microsoft Teams platforms for webinars and various chat sessions and so on. One of the examples is a 1-hour interactive webinar that was set up talking about coronavirus and people sharing their experiences about anxieties or things that they're doing well, not so well, observations that they've made, and also, as I mentioned before, sorting fact from fiction, because there's an awful lot of fiction out there, particularly in the social media. Then there's webcasts that are also being produced on a weekly basis. And this is actually about focusing not so much on coronavirus, but the way that we can work our way out of the current crisis and looking forward as well to the future, when hopefully a lot of the restrictions are no longer in place. But also there is some discussion about the here and now as well. In terms of information technology, I mentioned before the issues around cyber security and so on. So our IT people have been particularly active as well. I'd mentioned that we already had a lot of experience with people working remotely, and people working from home has been a long-established principle in Orica. I guess the thing that changed was the volume of people working at home and the changes that meant for our cybersecurity systems and our telecommunications, etc. So they've been working hard to make a whole lot of changes there. They've also been working on providing tips to enable people to become much more effective telecommuters as well, and particularly for things like video conferencing. I wouldn't say I'm an expert in it, but I'm slowly learning. Certainly, as I mentioned before, we've got a lot of platforms that we use commonly, but they've actually been looking at ways to make those systems more efficient so that they can be used more effectively by people working remotely. And then there's the whole cybersecurity issue around security alerts and tips that they're providing. So now just I've got a couple of slides on what we're doing for our operations and for our projects. I talked a little bit about all those other aspects about what are the various parts of a company like the CHES support and IT and HR are doing for us. But they are all fundamental then to feed into the changes that we're making actually out in the workplace and how we continue to operate. I should also mention too that Orica, being part of the mining services industry, in most countries around the world has actually been deemed to be an essential service, which from a business continuity point of view is fantastic. So we're very fortunate in that regard. But it also then enables us to extend that to some of the support people and suppliers and the like to help us with our ongoing operations. So yeah, we have been working to keep our operations open and also our customers' operations open too. As I said, we've had people who have expats who have chosen to stay in some very far-flung parts of the world to help the particular mine sites that they're working on to keep operating. I know of 3 people, for example, who chose to stay on in a mine in the boondocks of Mongolia, and they've been there for about 3 months now. They turned down the opportunity to be repatriated to Australia. But we also have to adapt our workplaces and so on in terms of limiting the number of people who are working there, achieving separation distances, the extra cleaning and decontamination that's required. So those are all factors that need to be put in place. We've adapted shifts, for example, shift rotations. We've also created split shifts. For example, at the Botany site, we have an HCB or hexachlorobenzene waste management project, which is a long-running legacy project. We have only a small group of people, small team of people working on that project, but we've actually split them into 2 separate teams, 2 separate day shifts. And they're not just organisationally separate now, but they're physically separate as well, so that they have their own meal rooms, they have staggered shift times as well, so that their break times and everything like that are staggered, and they actually work in different parts of the facilities for managing the HCB waste. And that's just one small example of those sorts of changes that have occurred. Obviously, there's been an increased attention to PPE, like face masks, gloves, if necessary. Obviously, in the manufacturing industry, a lot of the PPE is standard as anyway, like eye protection, etc. But there's also increased attention now to the cleaning of personal protective equipment and overalls and stuff like that to make sure that it's done in a manner that doesn't spread infection. There's temperature monitoring occurring at some locations, the rollout of sanitizer. In fact, even one of our manufacturing plants down in Melbourne has changed its operations to produce sanitizer as well. And that a lot of that sanitizer is actually being distributed to disadvantaged communities rather than for retail. And even things like food supply in a lot of our sites around the world. We've typically provided food to site workers and so on, and that has had to be reorganised now so that, again, infection control is managed through the distribution of food provision, distribution of food. And there's also the digital and virtual solutions that we're rolling out, not to us, just to ourselves, but also to customers to help them keep going. And I mentioned about the expats. I heard an update last week that as of Friday, in terms of illness for Orica workers, there's been 21 reported positive cases in Orica worldwide, and that's, as I understand it, mostly in Latin America and in Russia. I don't think there's any instances of it in Australia, but it just adds an extra dimension to the complexities of managing the workplaces that we have. And then there's things like business continuity plans. We've rolled out business continuity plans for all of our operations in different parts of the world, but also for our remediation projects, our major remediation projects. Very early on, we were provided templates and guidance for producing those, and then they've each been tailored for the individual circumstances. We have been affected by border closures. We've seen people, as I say, some of our own workers stranded in locations, but we've also had the situation where we can't send our own specialists out to locations. One such instance of that is where we're supposed to be at the moment doing detailed site investigation, intrusive site investigation on a site in Chile. And we were going to send out one of our specialists to oversee that and to direct it. But obviously that hasn't been able to happen. So that work has been put on hold until those borders are reopened. But we've also had issues the other way around too, like with the Yarraville remediation project in Melbourne. Work is supposed to have commenced on installing a thermal remediation process on the site, and that was going to involve obviously an American company, and they're all locked down there. So, and that whole work, that remedial work, of course, is all managed by various regulatory instruments. So there's a lot of work that's has to take place to get dispensations for the delayed work, and also, as I understand it, we're trying to seek dispensations to actually allow the Americans to come here to set up the process. But I don't know how that's going at the moment. That's just one instance. We've also had service providers even more domestically stranded, like we have an air emissions specialist based in Queensland. They're supposed to do statutory testing for us, facilities here in Sydney, for example, and until the very last moment, they weren't able to get permission to cross the border, but fortunately we've been able to have that happen. But that also required a lot of liaising with the regulators. And there has been quite a bit of that. Some of it's been ad hoc, responding to specific circumstances, but also some of it has been quite routine. Just as an example, our groundwater treatment plant at Botany produces treated water that is actually regulated by IPART. And very early on, IPART required all its licensees to commence weekly updates on the impacts of COVID-19 on the operations. So we've been doing that on a weekly basis. Some of the other things that we're doing on our sites is banning non-essential site visitors, obviously to avoid risks of infection and contact. We have pre-work health questionnaires for contractors and the particular visitors that the essential visitors that need to come to site. We also have new procedures around permits to work and accommodating the social distancing there. But also, as Ross and Peter both mentioned, the JSEAs need to include considerations of COVID-19. And we've been asking for some of our consultants and contractors to provide business continuity plans for some of the major works as well. And happily, I'm starting to see protocols and FAQs appear on our SharePoint site around return to office protocols, return to office for workers, which obviously is a positive move. But I think that'll only be a gradual thing anyway. So in conclusion, I suppose, at least for Orica, it's essentially, well, almost business as usual, but with a lot more, well, a bit more paperwork, a few more hygiene precautions, a lot less face-to-face, which is a bad thing sometimes, but a necessary evil. And there's been a few delays to some of our projects and some of our work. But on the positive side, there's also been a lot more working through this together. And I think that, well, that's one of the really good things that's come out of all of this, that it has demonstrated that sense of cooperation and, I suppose, collegiality. It's a terrible cliche now, but I hate to say it, but we are all in it together. And that's it for me. Thanks, Ravi.
Thanks very much, James. Another outstanding presentation. Just summing up your presentation, an overview of Orica, the company itself, the impact of COVID-19 to work and people, and management strategies that Orica has put in place, not just to manage the work, but also management strategies that really helps people who either are working from their offices or from their homes as well. It was also great to note that Orica has been distributing sanitizers to disadvantaged communities and providing food as well. That just shows how much Orica cares for not just their own people, but outside Orica itself. Thank you very much. And we will have, soon we'll have question and answer session. But before we go there, could you please join me in thanking James? And also, given that we have got Paul Nathaniel, absolutely outstanding scientist, and also a practitioner, and from UK, it would be great, Paul, a couple of minutes from you to just see how things are going at your end.
Well, good morning, folks. I now have my early morning cup of coffee. I decided a 5 o'clock start was worth it to hear what everybody else was saying, and I was right. I'm just going to share one thing that we're working on at the moment, and then I'm going to be quiet and listen to questions. The AGS is the Association of Geotechnical and Geoenvironmental Specialists, and has a number of working groups. And we're drafting guidance on ground investigations in a post-COVID world. The document is very much a draft. We have a meeting this morning. Document is being developed in Google Docs as a collaborative document, echoing some of the advantages and changes that we've been hearing this morning. And so I was particularly interested to hear what folk from Australia had to say about the way that you were facing the challenge. I think the short way, I emailed Peter at the end of his presentation and said, the way I summarized his presentation was keep safe. But three things, I can't remember how the coffee hasn't kicked in, but it's keep safe, keep working, and stay professional. And we're seeing in the UK a return to construction sites. We're seeing people continuing to work online and not needing to commute. James, I thought you missed that really big plus in your presentation. That's where the extra work's coming from. And I think I've seen a greater willingness to share information and share ideas, which can only be a good thing if we're going to tackle the broader societal challenge of land contamination. Thank you, Prashant, for promoting me to a panelist. I'll be quiet and look forward to the questions that may come through.
Thank you very much, Paul. It's great to have you in the panel. Ladies and gentlemen, so far I have received 4 questions. So I'm going to read out first the question from John Hunt to Peter Niederbaum. Thanks, Peter. Have you estimated the dollar value placed on a human life by Australia's response to the pandemic, considering the cost of the lockdown versus the likely number of lives saved relative to the value of a human life used in human health risk assessment and for insurance purposes?
Yeah, John's a stirrer, isn't he? He knows this is close to my heart. I think, in fact, Craig Dalton is the one who would be most best to respond to that. Yeah, no, but what this is doing is it brings up the very issues. It's quite a serious question, actually, but it brings up the very serious question of, how do we determine response, from our community to particular problems, and so it's obviously the economists are debating this very strongly around the world in terms of should you lock down, should you not, what is the cost? If you don't lock down, how many deaths will there be? And if you apply the value of a statistical life, which is sort of in the order of $4 or $5 million per life saved, therefore you can say the cost of not locking down, you can do the estimates, and the economists, when they go through that, usually show that if you let the virus rip, then the cost would be massive in terms of, or the equivalent cost in terms of lives lost. And that very same issue can apply in contaminated land. How do we balance the contamination risk? And where does that balance lie? Are we doing enough? Are we doing too much? And so that's a very key question that is the very same same problem.
Thanks very much, Peter. Hopefully, John was listening to your response as well, and he might come back. Here we have a question from
Ravi, just a different perspective. I think that the cost saved needs to include the value of preserving society functioning well. We haven't seen the NHS or the health services being overwhelmed. We haven't seen riots on the streets. The food has been in the supermarket shelves, and social order has been maintained. And the cost of losing that would be enormous. So there haven't been riots on the streets anywhere in the world that I'm aware of. And I think we really need to salute our leaders for taking very difficult decisions that have maintained peace and order in the population, as well as keeping more of us alive than would otherwise have been the case. So, yeah, great question, John, as ever.
Thanks very much, Paul. We have a question from Deepika Rajwar, and to the panelists. Are you appointing new employees amid COVID-19 pandemic at the moment? Anybody to answer that question?
Look, I could. I think we're being very cautious about taking on new employees until everything sorts itself out. So that's just a view of one consultant.
Ross, would you like to comment as well?
You're on mute, Ross.
Ravi, we're only this morning we were interviewing a person for a position. We're continuing to hire people, although, as Peter says, it's quite strategic hires that we're doing. We're also putting more people onto projects to get better training across the board, our staff as well. So both. We are hiring.
Thanks very much, Ross, and thanks very much, Peter. It's great to see that we are still hiring people. Noting also that COVID-19 has had a fairly significant impact on the local and global economy as well. So let's move to the next question. That's for Associate Professor Ferguson and also Professor Dalton. This is from Dilip Prankumar. My question is around COVID-19 infections in children/youth and how it has been recently reported that it might manifest into a Kawasaki disease, like inflammatory disease. I have a couple of queries about this. One, I understand that COVID-19 is a respiratory illness and the surface proteins have specific binding sites to the cells. is there evidence or studies indicating that these sites might not be fully developed in children, youth, resulting in a lower infection rate? And there's question 2. So if we respond to that, then I'll read question 2, Dr. Ferguson.
Yes, so look, I did respond to a previous question about children. You'll see it in the answered questions.
Yes.
Look, essentially, we don't really know why children are less affected. I have tried to track down data. I've seen it referred to about receptor presence in the respiratory tract, the ACE2 receptor. I've seen reference to the fact that children have less ACE2 receptors, but I haven't seen published data. So it's tricky, and I've asked my respiratory colleagues about that. They haven't come up with anything. They want to study it. The other big difference with children is their immune system functions in a different way to adults, both innate and their adaptive immune system. And that might possibly render them protected from disease. Children do get infected though. I think that they're underrepresented in case series because they don't get severely infected. So they're less likely to be admitted to hospital, tested, so they don't appear in the statistics. But the other element is that they haven't been a frequent index case within household clusters. Compare that with, say, influenza or measles. The children are frequently the initial case within a cluster, and in fact, children are very frequently affected in the household, and that's not the case with this virus. So it would appear that they're less likely to get infected. But don't have very good data. Now, Kawasaki disease itself can be triggered by a whole range of different infective triggers. We don't really know exactly what causes it. We suspect infection triggers. This has become a very common virus in some parts of the world, like Britain, and so one would expect to see rare diseases like Kawasaki potentially triggered by this virus. I don't know of any data from Australia. Of course, the virus itself could have be an indirect trigger of Kawasaki. It could render the person more likely to deliver a different sort of pathogen trigger into the circulation. And the virus is not actually the direct cause, it's just a secondary link there. So look, and I don't know anything about the particular community spread or origin of the Kawasaki cases.
Thanks very much for answering that, Dr. Ferguson. Kawasaki disease, perhaps for that we have vaccines.
No, there's no vaccine for Kawasaki. So
Okay.
it's quite a severe inflammatory condition that damages the large blood vessels, including those in the heart. So that's its big danger that causes heart disease.
And does it lead to death as well?
Yes, it can. Yeah.
Okay. Yes.
It's treatable.
Pretty serious. Yes. There's another question here from Dr. Ilya Rostami. He's another scientist. A question to our board/panel, please. Any updates on the hydroxychloroquine trials supposed to start recently? Question 2, any health workers taking part in these trials?
Look, I haven't been following the trials specifically. I think the evidence that exists currently is that hydroxychloroquine is extremely unlikely to be a panacea, either as a prophylactic agent or a therapeutic agent, notwithstanding President Trump's ideas about the drug war. Clive Palmer in Australia. It's scandalous, really, that Clive Palmer has bought up most of the hydroxychloroquine in the Pacific, and there's a shortage of drugs for malarial treatment in Pacific nations because of that. I certainly wouldn't be taking it as a prophylactic based on my knowledge of evidence, but there are randomized trials underway in parts of the world. Prophylaxis and treatment.
They probably have shares in that company.
Possibly. Yeah. So there is a randomized trial in Australia happening called the ASCOT trial. which is not going to look at hydroxychloroquine, it's looking at the gas, a couple of other agents, I think.
Thanks so much, Professor Ferguson. Question from Scott Millman. How much do you think habits will have a permanent shift in a post-COVID world? Or do we expect most things will simply snap back? If we do expect changes, in which areas do we expect we will see this the most? So any volunteers from the panel?
I could just start. Yeah, the working from home, I think, is something that will probably persist at a higher level than it was previously. You know, the use of IT. I think those are some of the things that we've mentioned in the presentation. So there are a couple of things that stand out immediately.
Anyone else?
I think that some of the personal hygiene aspects will hopefully be a permanent change as well, particularly attention to hand washing and sanitation. I think people are going to, I think people now have developed habits for washing their hands a lot better, and I'm hoping that's going to stay as well.
One of the things we debated in the UK in a panel on planning post-COVID is whether new houses should be designed more explicitly to allow from working from home, and whether you ought to require a home desk or a home office space to be available. So I think we might see the kind of product that the house builders are producing may change as well. And I'm really not missing the drive to work, I have to say. Or even the train to London, or even, dare I say it, the flights to Australia.
What do you think of particularly those people who are so addicted to going to pubs, for instance, or to casinos? Particularly casinos, for instance, with COVID-19, the number of people who have been frequenting that would have come down considerably. What do you think the local government, for example, state governments and federal government could put in place to make certain that we are able to maintain it to the level that we have right now? It's helping quite a number of families.
I would open pubs well before I would open casinos again.
Yeah. I thought so, yes. It's good. So we move to the final question here from Jackson King of Kafuenka. And the question is to Peter, Paul, and James. What is the overall perspective on anticipated impact on the completion works on these remediation sites and the ripple effects on the many addition sites that requires remediation vis-a-vis on the cost changes / implications to remediate these sites? James?
Go ahead, Peter.
No, I was thinking that's a pretty complex question. I was trying to think what the answer is to it, actually. I'm sure James and Ross will have an erudite yeah, from my perspective, I think things will go on. This issue of snapback and all that sort of business is probably a bit of a distraction. Contaminated sites will still remain. If you look at the drivers for dealing with contaminated sites, you know, we have a regulatory structure, a framework. That's not going to change, I don't think. And so the regulatory imperative to deal with contaminated sites is going to remain. There may be delays, some delays in the short to medium term, but I don't think it would require a major change in regulatory policy to change our, say there's going to be a significant change to the way we address contaminated sites. So I think the policy will roll on like a juggernaut, and these sites will require dealing with in due course.
Thanks, Peter. James, did you have something to say as well?
I agree with Peter. I think that it's merely the timing that's going to change on remediation projects, they are still going to be there. The drivers, one way or another, will still exist. It's just that the timing may change. From our point of view, the remediation projects that we have running at the moment, they all are running almost unchecked. The only exception really was the one down in Yarraville, where we simply can't get the people out from the United States to come and implement the work. But all the other remediation projects that we have in place are all charging ahead. It's interesting though, I think that we certainly seem to be engaging a lot more with the regulators at the moment for one reason or another. And there seems to be a lot more dialogue, which is possibly an encouraging thing. And I don't know whether that's because people are, because they're working from home, they're more available or whatever it is. But it seems to me that there seems to be a lot more cooperation and collaboration, and people making themselves available to get involved in some of the decision-making processes that need to be enacted now to deal with the particular circumstances. And it'll be interesting further down the track, although it's not going to affect Orica, but maybe it's going to affect GHD and AECOM and other companies alike, with the push for infrastructure projects and so on, whether that changes the impetus in the industry as well.
Ross, any comments from you? Thanks very much, James. That was great response.
I just wanted to go back to one question about changing habits. Another one that, and I know Paul will speak next. So one of the habits that I think may change is public exhibition of planning matters. In Australia, it looks like we've been able to make that quantum step to get planning agencies to utilise digital systems, digital frameworks, virtual offices to present planning issues. So I think that hopefully will change for the good. But I know that when I was talking with Paul and listening to the brownfields discussions last week, there were some real problems with that. So I might hand to Paul Nathaniel about that.
I was going to answer the question about changes, and it comes down to communication. I think that the culture has changed to allow for much more frequent dialogue between the consultant, the client, and the regulator. And going back to Peter's point, I think what that means is that there is the opportunity to think about the problem more deeply and therefore do more targeted remediation that will deliver bigger benefits. And I think that there's an old adage in certain parts of the UK about voting corrupt practices, which is vote early, vote often. But in this context, talk early, talk often. And Ross said that AECOM are good listeners. A good consultant will listen to the client and listen to the regulator and understand what the issue is and come up with solutions to that issue. And we've had the luxury of more time to refine recommendations that will ultimately deliver a better product for the client and save money at the same time. And I think that the way that the planning system in the UK is working, it's now routine for all planning application documents to be online, but as dead PDFs. And we're beginning to see public inquiries being live streamed, and we are beginning to see them being held online. We had our first jury trial in the construction technology courts done online during this past week. So the technology needs to catch up with the practice, but improved communication, bizarrely, is, I think, a benefit. But good communication starts in a pub or a coffee shop when you get to know each other, and then you can do the stuff online. So it's not instead of face-to-face, it's in between face-to-face more frequently. So better communication.
Just a very quick add-on to James's point, which I think is consistent with this message, that there is, I think the regulators are looking at what they're requiring, the outcomes, and the PFAS issue has been a stark point where the responses to PFAS are found to be very difficult, potentially demanding vast resources to deal with it, to achieve the desired regulatory outcomes. And so this debate that John Hunt flippantly mentioned about the value of a human life and so on, the whole issue of what do our regulators want, what do they require, and the fact that I think they are rethinking the area, and I think the COVID response is a prompt to that. It's probably the same also in the climate change area. They're starting to, I think, ask more fundamental questions about, well, how do we manage our country? How do we respond to these issues? And how do we balance all the factors? So I think we are seeing a change, and that discussion and debate that Paul and James talking about and so on is I think it's happening. Thank you.
Thanks very much. To all the contributors. I see that we just passed the time that we'd allocated for this workshop. I would like to first thank you all, but I also would like to invite Prashant just for final concluding remarks. The presentations were absolutely great. Gives us a picture of what the medicals think about COVID-19 and other infectious diseases as well, the implications of that on the work front. And it was great to hear from the practitioners, Ross McFarlane, Peter Niederbaum, and also James, the impact of COVID-19 on their work front, and also people and how they've put in place appropriate strategies that make certain that people could continue to work, at the same time ensure that the COVID-19 impact was minimized. So thank you from me. I would like to pass you on over to Prashant for you to take it from here, and including a master class that you want to talk about.
Thank you, Ravi. I just have a couple of announcements before we finish this virtual event. First of all, you will receive a short survey from us, so please take a moment to fill that. We will always appreciate your feedback. We will send you the slides for this webinar, as well as a link of today's recording when it's available. Many of you would be aware that we were to run our second summer school on contaminated site assessment, management, communication in March this year, but because of COVID-19, it was postponed to June. Now we have converted this course into an online masterclass beginning 22nd of June. We'll be sending details to our subscriber list very soon, and people who don't already receive our updates should visit the CRC CARE website to sign up. Our next free webinar is on the 3rd of June, and the topic is National Remediation Framework. You can find more details on this website. So that's all from us today. A big thank you to all the presenters for your time and sharing your knowledge. And finally, on behalf of CRC CARE, thank you to all the people joining this virtual workshop from around the world. Have a nice day, and see you next time. Thank you.